So we are going to go ahead and get started. Good afternoon, everyone. Thank you for joining us. My name is Elizabeth Aloni, and I'm with Schneps Media. Schneps Media is the largest local media company in Metro New York. We publish over 70 newspapers, magazines, websites, webinars, podcasts, and events throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, and Philadelphia. Today, we're very pleased to be able to bring you the colorectal cancer webinar, screening, treatment, and risk reduction. We appreciate your joining us to discuss this very important topic. And we are very lucky to have 4 top doctors who will be speaking today. Our goal is to demystify colorectal cancer, discuss why screening is important, provide warning signs of colorectal cancer, who should be screened and when, the current treatments available, and how to minimize risk of recurrence after colorectal cancer diagnosis. I'm honored to welcome my esteemed panelists today. First, I'd like to welcome Dr. Hans Burkholder. He is the Assistant Professor of Clinical Surgery at Weill Cornell Medicine and a board-certified colon and rectal surgeon at NewYork-Presbyterian Brooklyn Methodist Hospital. He currently specializes in the diagnosis and management of colon and rectal conditions. Welcome, Dr. Burkholder. Next, I would like to introduce Gokhan Ozuner. He is the Chief of Colon and Rectal Surgery at NewYork-Presbyterian Brooklyn Methodist Hospital. Dr. Ozuner has extensive experience in inflammatory bowel disease, colorectal cancer, and rectal prolapse, to name a few. He specialized in the use of state-of-the-art laparoscopic and minimally invasive techniques when treating patients. Welcome, Dr. Ozuner. Next, welcome Dr. Uqba Khan. He's the Assistant Professor in Clinical Medicine at Weill Cornell Medicine and Medical Oncologist at NewYork-Presbyterian Brooklyn Methodist Hospital. Dr. Khan specializes in the treatment of gastrointestinal malignancies and has done extensive clinical research in this area. Welcome, Dr. Khan. And finally, I'm very happy to introduce Dr. Meghaben Kothari. She's a gastroenterologist, Assistant Director of Hepatology, and Director of Women's GI Health at NewYork-Presbyterian Brooklyn Methodist Hospital. Dr. Kothari is board certified in several areas, including internal medicine, nutrition and obesity medicine, and gastroenterology with subspecialty training in hepatology. We're so lucky today to have such experts to be able to walk us through such an important topic. Let's get started by talking with Dr. Kothari. Welcome, Dr. Kothari, again.
Good afternoon.
Can you please share with us why screening is important and if it is safe to be screened during the pandemic?
Screening is very important, especially when it comes to colorectal cancers. The goal of screening is to find malignancies or cancers early enough, at which point we can easily treat them and prevent bad things from happening down the road. So when it comes to colon cancer, as we all know, screening used to start at the age of 50, but in the last 2 to 3 years, the guidelines have changed to start colon cancer screening at the age of 45. And the reason for that is we're finding cancers in younger people. And by decreasing the age at which we start screening these patients, we can decrease the number of patients that have bad outcomes. So the goal would be to find cancers at an earlier stage when they can respond better to treatment, as well as finding growths or polyps at earlier stages when we can remove them during the endoscopy itself. When it comes to screening during pandemics, we have taken a number of measures to ensure that patient safety remains our top priority. Some of the measures that we've taken in the last year is having all patients that come for procedures screened for a COVID test 1 to 2 days before the procedure. Also, we've taken social distancing measures in our endoscopy suite to ensure that patients are not in clusters and we can maintain their safety. Additionally, we've also started wearing, as everybody knows, protective equipment to decrease transmission or prevent any transmission of COVID. So screening is a priority and we should still be screened in a pandemic.
Thank you for that. And as you said, it's something that if you can detect it early, there's so many better options for treatment. So certainly not putting it off is so very critical. So thank you for that and assuring our attendees on that. What options exist for colorectal cancer screening?
Okay. There's a number of options out there for colorectal cancer screening. And the good thing to know is that there are options, so we can discuss them with patients, and depending on their preference, we can pursue one of the many options. One of the most commonly used methods is a standard colonoscopy, which is invasive procedure, but it is diagnostic and therapeutic. So colonoscopy entails having a prep the night before the procedure and coming in the next day to the facility to have the procedure, in which you do receive gentle anesthesia, and the procedure is performed by a gastroenterologist or a colorectal surgeon. And at that time, we can actually directly visualize the colon, and if there's any abnormalities like polyps, it can be removed during the procedure itself. With keeping that in mind, not all patients are ideal candidates for a colonoscopy, or they may find that that's not something they prefer. So other options include stool-based tests, which can be done at the convenience of their home. One of the newer tests on the market is something called a Cologuard, which I'm sure patients have seen commercials on TV for, which is a test that looks for blood or DNA changes in their stool, which is still considered a good alternative to a colonoscopy. And another option to consider is a special type of CAT scan called a CT colonography that can be used also for colon cancer screening.
So when you start the screening and hearing about these different types of screening, when you start screening, is there something in particular you should request or discuss with your doctor? Or is it really the doctor makes a determination about what test is best for you?
I think having an open discussion with your gastroenterologist would be a good place to start to know what your options are and which one you may be a better fit for, and seeing which one you prefer.
Terrific. Thank you so much. So what are some of the early signs that we can look for? I mean, obviously it's very important for us at 45 to start this process, but are there things that we should look for that are warning signs?
Absolutely. Well, firstly, the goal of a screening test is to, find pathology before you have symptoms. But if you do have symptoms, things to look out for are blood in your stool, changes in your bowel habits, abdominal pain, unexplained weight loss, are some of the things to start looking out for.
And if you do see those things, you should see your doctor immediately.
Yes.
And be sure to let them know. Okay. So once somebody comes in for a screening, how can they understand their test results, and what are the next steps there?
Depending on which test you do, the provider will discuss the results with you and will tell you a couple of things. One, what the meaning of the findings are, and if there are any interventions that were performed, i.e. were there any polyps removed. And based on those discussions, your provider will tell you what the next steps are. Usually, we talk about if it was a benign or a relatively normal exam, when your follow-up screening test should be.
Okay, very good. So you go for your tests, and then your doctor will kind of walk you through what those results are and help you understand what those next steps will be.
Yes.
Okay. Well, now let's say you're screened and there's nothing that is concerning to the doctor. When should a patient come back for their next screening?
Depends on the type of test they pursue. If you do have a colonoscopy and it is a completely normal colonoscopy and you're what we consider average risk, as in no family history of colorectal cancer, then 10 years is the recommendation.
Okay. And what about if you do? I mean, I think that's a good point that you bring up about family history. How much does that play into this? And does that affect the age when you should start getting screened?
Yeah, it absolutely does. We know that some colorectal cancers can be hereditary. So if you have a family member or multiple family members with certain types of polyps or cancer, we do start screening at an earlier age. It all varies on when your relative was diagnosed. And also it changes the frequency with which you should have follow-up screening tests. With family history, we recommend screening about every 5 years with a standard colonoscopy.
So that is a very big difference. It's important to know your family history and share that family history with your doctor to be able that you're doing the right screening at the right times.
Yes.
Terrific. Thank you so much, Dr. Kothari. I think you really brought up some important things for us to know, and knowing the process, I think, makes it easier for people to pursue and make sure that they're doing the right thing to take care of their health. So thank you so much for that. So sometimes after screening, a diagnosis might mean surgery. So I'd love to turn to Dr. Ozuner and Dr. Burkholder to discuss some of these things. I want to ask both of you, what typically leads to the need for surgery? Dr. Ozuner?
The main thing is if gastroenterologist or any endoscopist performed a colonoscopy and they found cancer. Let's say they take out a polyp or they see a cancer, they take a biopsy. So if there's a cancer diagnosed in pathology when you take a biopsy, then the patient will need a surgery. But we don't usually rush them to surgery. We do a workup. We evaluate the patient from the medical perspective, get a CT scan of their abdomen and pelvis, chest, get some blood work, CEA levels, and then once we try to stage the patient, see if it's an early stage colon cancer, if there's any metastatic disease, meaning if there's any spread of the tumor or to other organs like the liver or the lungs or any place else. And then we decide on the optimal treatment. In general, if it's an early cancer with no spread, and I'm talking about colon cancer, then surgery would be preferable because unfortunately, that's no other treatment is as effective as surgery, especially in these early cancers. So again, I will leave the microphone to Dr. Burkholder and see if he has any other input.
Dr. Burkholder?
Yeah, so I think that's an excellent question. And, I think patients who have been told they have cancer, obviously it's a traumatic event for them, and it's a really scary thing. And so our goal when we're seeing patients who've recently been diagnosed with cancer is to try to help them understand what their options are. And, if, like Dr. Ozuner was saying, the testing doesn't show that the cancer has spread to other places, to really try to give those patients hope that our goal with the surgery is to do it as painlessly as possible and to give them a cure where hopefully, 10 years from now, the colon cancer is just a bad memory for them. But it's always very traumatic for patients. And, part of our goal is to help people make this feel like it's a controllable thing that we can help them walk through. And our real goal with the surgery, as I said, is to do the most minimal possible surgery that's going to be the most effective. And if we can use advanced laparoscopic techniques, which both Dr. Ozuner and I do, the recovery is much, much easier than the old method of doing a big open surgery with huge scars. So
that's incredible. That type of, laparoscopic surgery is really incredible and probably has changed so much of the after surgery. But I think, what you're talking about brings us to the next question. What can patients expect before, during, and after surgery? And obviously it depends what type of surgery, but perhaps you could share a little bit more about that with us.
Yeah, one thing I want to clarify is this: we're talking about colon surgery, and a lot of times colorectal cancer is put in the same bucket, and rectal cancer is sometimes handled a little bit differently as far as management. So patients who have rectal cancer, they sometimes benefit from other treatments first, or a combination of treatments with chemotherapy and radiation. So, but for colon cancer, when they do need surgery, first of all, the patients, if they have any questions of what type of surgery and what part of the colon the tumor is and which part of the colon will be removed, all these questions will be explained to the patient. And, depending on the size of the tumor or depending on the location, a segment of the colon will be removed. So the patients, like any other surgical intervention, they will be, in general, we like them to have a bowel prep, meaning just like for a colonoscopy, have a bowel prep the day before, and then usually stay NPO, meaning no food or drinking the day before, after midnight from the day before surgery. And then they will have their surgery. Now, as Dr. Burkholder said, if we do laparoscopic surgery or minimally invasive surgery, usually after the surgery, you remove that section of the colon which harbors the tumor, and then you hook the two ends together. It's just like plumbing. And then the patients usually stay in the hospital for 2-3 days, and then they go home, and the recuperation at home, depending on how active they are or what kind of work they are, is usually 2 weeks, maybe 3 weeks. And then they go back to their normal life.
Okay. Dr. Burkholder, would you like to share a little bit more about that process? That was very informative. Thank you, Dr. Ozuner.
Yeah, so I think Dr. Ozuner explained it well, but I would also kind of reference something Dr. Kothari mentioned. When we're doing colon cancer screening, we're making sure that people are COVID negative. The employees in the hospital all have to answer surveys every day to make sure they have no symptoms of COVID. So we're trying to protect people from COVID over the time of the surgery by making sure that everybody around them has either been tested or has answered surveys demonstrating no symptoms. I saw Kevin Sammy in the audience asked a question about what does post-surgery look like. He said, how long is recovery time and any specific steps patients need to follow afterwards? I think that's a good question. So to start with the day of surgery, people come into the hospital, they go through the procedure, which depending what we're doing exactly takes variable amounts of time. But they wake up, and usually we're giving people liquids to drink that same day, trying to encourage them to get up and walk and move around as much as possible. And the more active patients are after surgery, the better they're going to feel, and the quicker they're going to feel back to normal. So I think most people are going to stay in the hospital somewhere between 2 to 5 days, depending on what their recovery looks like. And usually by the time they're going home, they're eating, their pain is pretty well controlled, but they're going to take it easy for a week or two while they're at home. And it may be a month or so until they're really feeling back to some semblance of complete normalcy again. But with the laparoscopic procedures, people get better a lot more quickly than they used to with the open surgeries. So it's exciting to be able to offer people these more advanced techniques.
That is phenomenal, because part of the healing and the overcoming is getting back to normal and feeling like yourself, and being able to do that quicker is really tremendous opportunity for people. So you keep mentioning these different procedures. Would you each tell me a little bit about the types of procedures that are done? You kind of touched a little bit, but if you could get more into each of those, that would be helpful.
Well, the colon has different parts of it. The right colon, the transverse colon, the left colon, the sigmoid colon. It's just like different sections of the colon. So depending on the location of the tumor, that section is removed. If the tumor is in the right colon, then you proceed with what we call a right hemicolectomy. If the tumor is in the transverse colon, you may extend that to an extended right hemicolectomy. And the goal being removing the tumor and removing all the blood supply and the lymph supply to that section of the colon. If the tumor is in the left colon, then you do a left hemicolectomy, meaning you resect the left segment of the colon. And if the tumor is in the sigmoid colon, which is between the rectum and the descending colon, you remove that section. And again, the goal being removing the blood supply and the lymphatic supply. And even though we do laparoscopic surgery, as Dr. Burkholder said, we do what's safe for the patient and what will is curative or potentially curative to the patient. So sometimes when you do laparoscopic surgery, if there's any reason we cannot see, or there's some other circumstances with scarring, adhesions, and you can't do the appropriate cancer surgery, then we will have to do open surgery. But that's a better option, that's safer, instead of taking shortcuts. And we never take shortcuts. When we operate, we want to take care of the problem. So even though open surgery the recuperation may be slightly longer, but the difference is minimal, maybe 2 days or so longer stay, and maybe a couple of days more recuperation. So that's in a nutshell what I have to say, and I'll let Dr. Burkholder elaborate.
Thank you, Dr. Ozuner. Dr.
Yeah,
Burkholder?
I don't have much to add. I mean, I think he's described the procedures well, but our goal with surgery is to remove the affected section, do our best to give the patient a cure from the cancer, if that's what we're treating, and get them better as quickly as possible. And he's absolutely right. The laparoscopic procedure is preferable in the appropriate patients, but there's times there's no other options. And our goal is to treat the cancer and get people back to normal.
As you're talking about these procedures, I was wondering, are typically after these procedures, are people able to resume their life as they had previously?
Absolutely. I mean, removing even if you can remove the whole colon, and it wouldn't affect anybody in an adverse way. The colon is more a reservoir as far as, with the stool and everything. And if you remove the colon, then the rectum acts like that. There's obviously some absorption and stuff going on, but in general, as far as the long-term effects, it wouldn't affect anybody as far as nutrition-wise, as far as metabolic-wise. So it's very safe to remove a section of the colon. If you remove the whole colon, of course, you may have a little bit of, increased stool frequency and things like that. But again, it will not affect your overall well-being.
Wow, that's a weight off one's shoulders for sure. Can you share with me the collaboration that you have with GI doctors and the larger care team when you're doing surgery for a patient?
Well, we always communicate with the GI doctors who refer the patients to us and discuss the patient with them. And then once we do the surgery and, depending on the stage of the tumor, we may refer them to Dr. Khan or some oncology doctors to evaluate whether they would benefit from further treatment, such as chemotherapy. That's the collaboration. And now at Brooklyn Methodist, there's like a multidisciplinary center where patients with colon cancer, they can come in, they can see GI, colorectal, and oncology, depending on, but that has to be scheduled ahead of time.
Dr. Burkholder, thank you for that. Did you want to add something to that?
The only other thing I'd add is we also have a multidisciplinary tumor board where many of these cases are presented. And it's a meeting involving physicians from different specialties, and we each have our own area of expertise, whether it's radiation treatments or medical oncology treatments or surgery. And we, discuss these cases and come up with a multidisciplinary plan often before any treatments have even been started.
Wow, so beyond just having an experienced surgeon, you also have this team that works together to discuss your case and be able to get input from all these other professionals. Correct,
because it's very important that we all are in agreement of what the best individualized care plan is for that person, because it's not cookie cutter medicine. Everybody's a little different, and we have to make sure we're meeting the specific needs of the patient that we're seeing.
That's tremendous value to a patient, both the fact that you have that type of board that confers with one another for the best outcome for the patient, but also the fact that you have the whole team together in one place for people to be able to access these different elements of the needs that they have. How do patients end up with a surgeon? I mean, certainly it's wonderful that all these attendees are having an opportunity to meet you and Dr. Ozuner today. How do people that aren't as fortunate enough to be on a webinar and get to meet you, how do they end up with a surgeon?
Well,
how do you recommend that they end up with a surgeon too?
Well, in general, the primary care physicians or the gastroenterologists, they refer patients to surgeons. And, there's a lot of factors involved in that. Sometimes insurance is an issue, sometimes other factors come into effect. But we usually get referrals from primary care physicians and gastroenterologists. And it's important that patients do seek a specialist when they are diagnosed with colorectal cancer, meaning they should see a colorectal surgeon who, Dr. Burkholder and I, this is all we do, and this is our specialty. So that's that's our referral basis in general. Or sometimes you get patients who you're operated on, and their family members, they refer patients, they refer their relatives or friends to you as well.
Nice, very important. Do you recommend that people go for several opinions or go to meet with several surgeons? What do you recommend in that regard? Or do you recommend that people go with who their GI doctor recommends because they're part of a team and that there's a benefit to that?
Well, I mean, as long as they see if it's a pretty much standard, or if it's a pretty much relatively simple colon cancer, meaning it doesn't have other factors involved. Sometimes patients have comorbid conditions, or there's like multiple lesions, or, there are other factors. Where it's a straightforward colon cancer surgery, I think they can go with whoever their GI recommends, but it never hurts to get a second opinion. I mean, patients should be crystal clear in that the treatment that is being offered to them is the right treatment and is going to potentially cure them from the disease. So I always encourage patients, if they have any questions or if something is not clear to them, they should go for a second opinion. I don't know what Dr. Burkholder's opinion is in that.
Well, I think most people don't need a second opinion, but I think it's very important that when you see a surgeon, that you have rapport with that person, feel comfortable with them, and if you have questions about whether what they're telling you is what you actually need or not, I think it's not a bad idea to get a second opinion, but I don't routinely send people for second opinions. My one caution with second opinions would be if you've been diagnosed with cancer, you don't want to waste, inordinate amounts of time, shopping around and getting a whole series of opinions. At some point, if surgery is an option for you, you want to do surgery in a reasonable amount of time so that you have your best chance of getting cured from the cancer.
Yes, thank you. As Dr. Kothari had shared with us in the beginning, it's very important to detect this and deal with this right away and be able to improve your chances of being able to live a very normal life afterwards. So thank you for that. Thank you so much, Dr. Ozuner and Dr. Burkholder, for giving us a key information on surgery. So when a patient is diagnosed with colorectal cancer and either before or after surgery, I wanted to talk to Dr. Khan about the different treatment types that are available. Dr. Khan?
Yeah, so thank you very much. So that's a very important question. So I typically see a patient after, he or she has undergone the surgery. So when I see a patient, I tell them that the treatment of colon cancer depends upon the stage of the cancer. And just for the understanding of our audience, stage means how extensive the cancer is. For colon cancer, we have 4 stages, meaning that it starts a small lesion, and as it grows and involves other structures and organs, it's become 2, 3, and ultimately 4. Stage 4 means the cancer has spread to other organs like liver and lungs. So I divide the cancer stages into 2, like early stage, meaning stage 1, 2, and 3, or late stage or metastatic stage, which is stage 4, because the treatment options are different in those 2 areas. If it is an early stage cancer, meaning stage 1, 2, or 3, the main treatment is the surgery. Surgery will give this is the cure basically. And then when I see the patient, I usually, see the patient within 2 to 4 weeks after the surgery. Then I look at the pathology report. Pathology report is basically when Dr. Burkholder or Dr. Ozuner take out the cancer, they send that cancer tissue to the pathology lab. So they look under the microscope and see how big the tumor is, whether there are lymph nodes involved or not. So I look at all those factors and then determine whether patient needs any chemotherapy or not. And the whole idea of doing further treatment after surgery is to reduce the chances of cancer coming back in the future. Because even after surgery, there's still a chance that the cancer, unfortunately, can come back in the future. So that's why we sit together with the patient, go over their pathology report, and determine what's the risk of cancer coming back in the future. And then according to that, we determine the treatment. Now, what kind of treatment?
Mhm.
So the treatment is typically chemotherapy. And the chemotherapy is basically is medications. They can come in oral medication like tablets, or it can come in IV medications also. They are typically given at minimum of 3 months and maximum of 6 months after surgery. So it's not like lifelong chemotherapy. It's just a limited, amount and duration of chemotherapy that we give. And again, the whole idea is that after giving 3 or maximum 6 months of treatment, we want to reduce the chances of cancer coming back in the future. I won't go into the detail of different types of chemotherapies, but there are different names like FOLFOX, capecitabine, and so forth. Those are the common chemotherapies that we give. But if the cancer has spread to other organs, that means that is a stage 4 cancer. In those cases, we typically don't do surgery. We start with chemotherapy. And the idea is to shrink the cancer and stabilize the cancer as long as possible. Okay. And, with recent advancements, in oncology, some people can live for several years, even if they have a stage 4 cancer, because we have several treatment options for that. Not only chemotherapy, but we have something we call targeted therapy. That means that we look at the DNA of the cancer. So when the cancer or biopsy is done, we do some special testing on the tumor to identify certain mutations, and then choose specific treatment for that specific patient. And sometimes it works very well. In addition to that, we also use immunotherapy. People may have heard about immunotherapy, and the whole idea of immunotherapy is that we activate the immune system of the patient to kill the cancer. So, and that is much better than chemotherapy in terms of tolerability, side effects, and if they do have a response, they respond very well and for a very long period of time. So just to summarize, your answer to your question, we have several options. It depends upon the stage of the cancer, and people can live many years and long life, and we can potentially cure those cancer with the treatments that we have.
That sounds wonderfully hopeful. Thank you, Dr. Khan. Can you describe for us the collaboration with Cancer Support Services and the benefit to collaboration with Weill Cornell Medicine, which is an academic medical center?
Yeah, so I think it's very important because we collaborate and, very closely with Weill Cornell Medicine. And we know all the physicians over there, and we always share patients with each other. So there are several avenues through which we collaborate. Number one is that we have, conferences that happen on a weekly basis. For example, in oncology, so any new patient, let's say I see in my clinic, I discuss with a weekly meeting with, Cornell, and we discuss as a group that what should we do for this patient? And we come up with a consensus, and then we go back to the patient and we'll tell them that after discussion with all the experts, we think option A is better than option B for you. So that's typical, for any new case. Then we have tumor boards, as Dr. Burkholder and Dr. Ozuner mentioned earlier. Tumor board is basically a conference where all the experts sit together and review all the cancer patients, their history, their pathology report, their CAT scan results, and come up with a consensus. So we do as a group here in Brooklyn, and also sometimes we also do with Cornell as well. And lastly, in terms of collaboration, I would say clinical trials is something that we always offer to our patients. Clinical trials means that if we think that there is something new medication or treatment option that is still not approved by FDA, we want to check it and see whether it works or not. And a lot of time it does, and patients can get benefit way before then it's actually approved in the future. So so if there's a clinical trial available here in Brooklyn and Methodist Hospital, we try to do it here. But we, sometimes some clinical trials are not available. We can always send those patients to Cornell, and we, jointly take care of that patient together. So those are some of the things and support system that we have in collaboration with Weill Cornell Medicine to help our patients.
Really important. I mean, a tumor board and then a board where you discuss the treatment options. I mean, this is a tremendous value for someone who's going through this to know that there are so many experts looking out and looking in. So that's very heartening. Thank you. How can our attendees minimize the risk of getting colorectal cancer or the recurrence of it? Is there a certain diet or exercise? What do you recommend?
Yeah, so the way I answer to my patients, so typically I see patients who are already diagnosed with colon cancer. So this is a common question from the patient that, doc, I know I have cancer, I'm treated with it, I have several years to live. How can I reduce the chances of cancer coming back in the future? So the way I answer that question is that, first of all, some of the basics, I need to know what stage of the cancer it is. The lower the stage, mean stage 1, the less the chances that the cancer will come back in the future. The higher the stage, the more the chances that the cancer will come back in the future. So, so we do certain things in our clinic to reduce the chances of cancer coming back. Number one, once the patient finishes his or her treatment, that includes surgery and chemotherapy. And I just want to mention here, chemotherapy itself reduces the chances of cancer coming back in the future. So that's given. But once the patient finishes his or her treatment, we do something called surveillance of the cancer, meaning that for the next 5 years, we see the patient very often in our clinic. I typically see those patients every 3 months. I do physical, ask questions, any warning signs of cancer coming back, do blood work, and we do CAT scans every 6 months or to a year for 5 years. And the whole idea of doing all these things is to, God forbid, if the cancer comes back, we catch it early. Okay. In addition to that, colonoscopy is also important, even after you are diagnosed with cancer. We do, routine colonoscopies after that. Now, that's what we do, to help the patients. From the patient perspective, couple of things that are important. Number one, diet, and number two is physical activity or exercise. These are very basic things, but trust me, they help. Okay. In terms of the diet, I typically advise my patients to, you don't have to go crazy about the diet. Sometimes people, totally change their diet. No, you just have to use common sense. And that means use a lot of fruits, a lot of vegetables. If you like meat, try to focus on white meat, like fish, like chicken. I typically tell patients not to eat, red meat, because there is a little bit higher risk of cancer with red meat. Then, a few other things, like if patients are smoking, I advise them not to smoke, cut down on the alcohol use, and so forth. And then obviously exercise. Exercise means, it doesn't mean that you have to join a gym to do exercise. It means that, if you have 1 week, you should do 30 minutes, a brisk walk in the park for 4 to 5 days a week. And that should be sufficient. But if you are more healthy and, younger age, you can do, more strenuous exercise as well. So I would focus on diet and exercise. I think that will definitely help you to reduce the chances of cancer coming back, and also seeing your specialists, including myself and the gastroenterologist and the surgeons routinely to look after any signs of recurrence.
Thank you so much. And for those who did not have colorectal cancer, obviously important to diet, exercise, and make sure that you are screening and that you are looking at your family history. All those things are so important. Thank you. What are some of the common health disparities that exist? And can you share about any steps that are being taken to address these disparities?
Yeah, so that's a important question. Unfortunately, with colorectal cancer, there are few disparities. It's a very broad question, but there are gender disparities, there are racial disparities, and I'm gonna focus on those. In racial disparities, unfortunately, colorectal cancer affect African American patients more than any other race in United States. And subsequently, there's a higher mortality. People die more from colorectal cancer in African American population than compared to any other race, for example. And we don't know exactly what is, the underlying cause of it, but there are a few things that people have tried to explain that. Maybe it's access to care, lack of screening, which is very, very important. Actually, you need to get screened, at appropriate time points at your age. And I think we should start at the age of 45, especially in African American patient population, so that we can detect the cancer early on. And unfortunately, in my clinic, I see even younger patients than 45, in their 30s, sometimes in their 20s also. We diagnose cancer in those cases. So screening is obviously very, very important to mitigate this racial disparity. Age, gender is also disparity. We see colorectal cancer more in male than females. So, but the screening guidelines are the same. So we start at the same age when we screen the colorectal cancer. So those are some of the disparities that we come across with colorectal cancers. Now, what are the steps that we as a group, as a, clinicians in Brooklyn, what we are doing to help that or close the gap in the disparities? So first of all, we give the same kind of treatment to every patient who come and see us, so that we give the standard of care per the guidelines. Whether that patient goes to any other state or a city, he should get the same standard of care, and we provide the same standard as per the national, international guidelines. So that's one thing to help the patients to improve the disparity. Then we have a lot of support system at our cancer center in Brooklyn that helps a lot of the issues, especially related to the access of care. Patients with minority patients have a lot of issues with their transportations and, social issues, financial issues. We tend to help. We have patient navigator to help them. And the whole idea is the disparity exists and some of the factors that causes that disparity, and we try to help them close the gap. And then there are some biological reasons also in disparity. Not all the cancers are same. We have started few studies, clinical studies, to look at the different kinds of cancer from different races and see whether they are different or they don't have any difference. Whether that can explain the disparity in outcomes of those patients. So we are collaborating with Cornell, and we are doing a lot of studies to study that difference in the outcomes of these patients.
Very important. So being able to make all of this access available to everyone in an equal manner, and being able to research to see where the differences are and be able to address those differences. Those are really important things that are happening at NewYork-Presbyterian Brooklyn Methodist Hospital. So thank you for sharing that. Thank you so much, Dr. Khan. Thank you so much for this wealth of knowledge from all of you. And I'd like to be able to get to our attendee questions, because we have a lot of questions that people have for us. First, I wanted to get started with Julia, and this would be, I guess, to Dr. Kothari. Julia is 84 years old, and it's been 10 years since she has had a screening. Does she need to be screened again?
So the recommendations are to screen normal, healthy people up until the age of 85. So if she's 84 years old and in relatively good health, she should be screened for colorectal cancer.
Thank you.
And she has a number of options to use to be screened, which is good to know for her also.
So she should talk with her doctor about those. Terrific, thank you. Lana wanted to know, how often do you have to take the Cologuard test?
Okay, so we briefly talked about timeframes. The Cologuard test is performed every 3 years if your last one was negative. But all patients should keep in mind is that if you have any test, any screening test that's positive, it should be followed up with a colonoscopy.
Okay. And if you do, you're saying the colonoscopy you were talking about every 10 years, can you use the Cologuard test instead, or do you recommend also every 10 years having a colonoscopy?
At that interval, you can decide what screening test you would like to pursue if you no longer want to have a colonoscopy. So it can be followed up with an alternative test, a stool-based test like Cologuard, or a simple test called a FIT test.
Okay. Actually, Terry has a question that is right along those lines, which is, she wants to know, what is the best test to get screening? Or are they all the same? So Karen also just jumped in. How accurate is the Cologuard test? So can you guide us around that?
Yeah, not one test doesn't fit all patients, so that's important to know. As a gastroenterologist, we prefer doing a colonoscopy because it is diagnostic and therapeutic. So if there's any abnormalities that we can visualize during the procedure, it can be most likely addressed during that procedure. As in a polyp, if we find that, which is abnormal tissue growth, which can eventually turn into cancer if it remains inside the colon long enough, during a routine colonoscopy, the endoscopist can actually remove the lesion. But if you have any alternative tests, like the CAT scan we discussed, or a stool-based test, if those are positive, you will need a colonoscopy to address why that test was positive.
I understand. Thank you. And so you don't need to see a surgeon to have a polyp biopsied?
No.
Okay. So Stephen has a question about what exactly is a polyp?
So polyp is a abnormal tissue growth. It is precursors to developing cancer. So there's different stages of polyps, and usually it's based on the size of the lesion as well as what we call the pathology of the lesion. And it's the tissue that you want to remove because it is abnormal and it has the potential to turn into cancer.
Thank you. That clarifies it. I think, Dr. Khan, this might be for you. Mary wants to know if you've had previous cancer, such as breast cancer, should you have the colonoscopy in 10 years or less time? She said, I was told 5 years by her oncologist, but her medical doctor says 8 years. So she is confused.
I think maybe I'll leave it to Dr. Kothari to answer that question. But what I would say is that it pertains to, the family history also here. If there's a family history of other cancer, and there are some cancer, if you have, for example, breast cancer or ovarian cancer, it can also increase your risk of colon cancer if you share the same genes or mutations. So then, the guidelines changes and depends upon that specific, hereditary or familial disease that you have. But I'll leave it to Dr. Kothari to address the, when to do the colonoscopy in that specific scenario.
Yeah, to echo what Dr. Khan says, it depends if you have other cancers along with breast cancer that put you at higher risk. In that case, we talk about hereditary risk factors or hereditary syndromes, which then determine how frequently you should have a colonoscopy. But it depends on if you've been diagnosed with a hereditary syndrome before we shorten the interval.
So are there particular other cancers that where you tend to see a patient will also have colorectal cancer? Are there certain links between other cancers?
Yes, there are. And the way we find it is we do genetic testing to know that, whether there is a link between that or not. And I typically do that in my clinic when I see a young patient who develops the colon cancer without any other risk factor, or there's a family history, just as someone asked that question, that had breast cancer or colon cancer in another family member, or brain tumor or something like that. Those could be connected actually. So, but we need to confirm that, and the way we confirm it is we do genetic testing, and genetic testing is basically a blood test to see whether there are any mutations or not.
So do you recommend this type of testing for an individual who has had cancer in general in their past or in their generations or genetically?
Not for everyone,
Okay.
but in certain cases when, if there's, family history of colon cancer or some other cancers, and also the age. If the patient is diagnosed at very early age, then most likely there could be, genetic alteration present.
Thank you. Along these same lines, Carl had his father, uncles, and cousins died of colon cancer in their 30s. And Carl, I'm so sorry to hear that. So he obviously has a hereditary concern. So would that be a case where you would say, see a doctor early, get tested, and also do screenings early?
Absolutely. If there are a number of relatives with colon cancer, there definitely may be a genetic link that, can be determined based on the family member's history. But in terms of screening for him, if he had family members diagnosed in their 30s, he should be screened relatively early as well, as early as into the age of 20. It's usually 10 years before the youngest family member that was diagnosed with colorectal cancer.
That's very important information. Thank you so much. Terry wants to know, if you don't have a colonoscopy, how would you know if you have polyps? Would there be any other way to know that?
So when we do the alternative stool-based test, we look for either blood or DNA changes. As we stated earlier, polyps are abnormal growth, so they're not normal tissue. What we find is that they either shed some small amounts of blood, which may not be grossly visible, or have DNA changes that can be detected in the stool, and that's what the Cologuard test or the fecal immunochemical or the FIT test will detect. So it has to be, without having any large symptoms or alarm signs, stool-based testing can detect presence of polyps.
I just want to interject something to Dr. Kothari. First of all, I also want the listeners that there's an open access colonoscopy route where I think Kothari leads the program, that patients who do want to have colonoscopies, they can ask their primary care doctors to schedule them for colonoscopies. And the other thing I want to want to interject is, unfortunately, all the other tests like Cologuard and FIT tests, these are not accurate for early stage polyps. They're more accurate if you have early cancer, and colonoscopy is still the gold standard diagnostic tool. So all these tests are subpar to colonoscopy. If colonoscopy has an accuracy of 98, 99%, especially if you have a good bowel prep, all the other tests, they're way down as far as accuracy. So if you want to be, as Dr. Kothari said, there are different options, but the the best option is still a colonoscopy.
Thank you for that. Robert wanted to know, should we get colon cleansing? Does this help avoid getting cancer? Who would like to take that?
Colon cleansing has not shown to reduce development of colorectal cancer or even colon polyps. Some people feel that colon cleansing actually may do some more harm because it changes the gut bacteria or the microbiome of the GI tract in a not beneficial way.
I totally agree. I think it's something detrimental, shouldn't be done. It's a money, it's how people make money, and it has no scientific benefit.
Very important information. Thank you. Daniel wanted to know, are there some other risk factors? We talked a little bit about other cancers, other than genetics also, that makes someone a higher risk for colorectal cancer. You mentioned African American. I don't know if that would be considered a higher risk, but if you could share with us.
So there are several risk factors that we know can increase the chances of cancer in someone. And as you mentioned, family history is one. If there's hereditary, genetic problem that exists, and others are, race and sometimes gender as well. Obesity is another risk factor. Smoking is a factor. High consumption of alcohol is a risk factor. A lack of fiber diet, fruits and vegetables, that's a risk factor. Consumption of a lot of red meat is a risk factor. So those are, common risk factors that can increase your chances of cancer in the future. But there are certain, diseases also, like we call it inflammatory bowel disease, can also increase your chances of cancer in the future, and that's why we do screening earlier or more often in those cases. So those are some of the other common risk factors for the colon cancer.
Thank you. So a lot of those things that you recommended that we do to prevent colon cancer are the things that would put you in a higher risk for getting colon cancer.
Absolutely, yeah.
We have a question along the lines of, you said something about some other illnesses or some other issues that people have could lead to, or can say that they may be at a higher risk for colorectal cancer. Esther said, she mentioned a bunch of different things like SBS, hemorrhoids, lesions, squamous cell. She wanted to know if any of these things could make you at a higher risk to get colorectal cancer.
The answer is no, absolutely not. The only risk, as Dr. Khan mentioned, is if you have longstanding IBD, ulcerative colitis, or Crohn's disease for more than 10 years, and especially if it involves your whole colon, then you have an increased risk. With diverticular disease, hemorrhoids, perianal, none of that increases your risk.
Thank you. I'm sure Esther is having a sigh of relief. That is great news. Steve said, you mentioned adhesions or scarring that forms between sections of the intestine or bowels. Can these become problematic for bowel movements?
It certainly can. I mean, but unlikely, but it certainly happens. Sometimes you get scarring and kinks in the bowel, and they can affect your bowel movements. But that's not the purpose of this discussion.
Thank you for answering that, though. Ellen has a concern. I think this speaks to how COVID has affected people's making sure that people are going for their colonoscopy. She said, I have continuing post-COVID neurological symptoms, and I'm overdue for a colonoscopy. Would the sedation be a problem for me? And I think, there are a lot of questions around COVID, and we really want to encourage it, but making sure that you're still getting your screenings. But what about something like this in particular? What would you recommend if she was your patient?
That's a tough question. There's a lot that we don't know about in terms of the post-COVID recovery symptoms. If there are any neurological symptoms, being evaluated by a neurologist would definitely be important. And if this patient is just average risk, maybe a colonoscopy with anesthesia may not be the best choice at this time. She can consider other testing to be screened for colorectal cancer.
Oh, the other thing I want to say is you can have a colonoscopy without any anesthesia. I mean, I had my colonoscopies. I drove in, I had my colonoscopy, drove back, so patients. So it's not for everyone, but for a certain group of patients who have, they can have colonoscopies without any anesthesia. But as Dr. Kothari said, they can have other screening modalities, or if the patient can have a colonoscopy without any sedation.
Certainly, it sounds like the message is make sure you have screening and do not put off screening, because as we started out with the conversation, screening can reveal information that can be very important, and timing is so very important with colorectal cancer. Thank you so much. We could go on forever here. You've been so generous with your time, all of these incredible doctors, and I truly appreciate it. I did share with everyone, if they want to get more information and connect with the team at New York-Presbyterian Brooklyn Methodist Hospital, you can call 718-246-8600. Again, I put that in the chat. Also, we're going to send you an email tomorrow. That'll be included in that email as well, so you can reach out to the team. We also are recording this webinar, and it'll be available on the Schneps Media YouTube channel. So you'll be able to watch it again. You'll be able to share it with your friends in your community. So I want you to please go ahead and do that. And the biggest message of all, please make sure you get your screening and that you protect yourself, and information is power. So make sure you go see your doctor, be screened. And thank you so much for joining us again, Dr. Burkholder, Dr. Khan, Dr. Kothari, Dr. Ozuner. Thank you so much for your time today. Truly, truly appreciate it. And thank you to all of our attendees for joining us. Please stay safe, stay healthy, and we'll look forward to seeing you on another webinar shortly. Take care, everyone.
Thank you.
Bye.
Thank you.